Neurology Quiz number 102. Describe the etiology, clinical features, investigation and treatment of rippling muscle disease or RMD. Rippling muscle disease is characterized by rippling movements over the muscle which are induced by muscle stretching or percussion, as well as muscle stiffness and muscle hypertrophy. Clinical features: 70% of patients with RMD have visible muscle rippling, which are wave-like contractions that resemble worms crawling under the skin that last 5 to 30 seconds. This typically occurs on stretching the muscle and is most prominent in the proximal muscles, especially the quadriceps. The rippling movements can also be induced by rapid tapping of the muscles. This video demonstrates prominent waves of muscle rippling elicited when the patient stretches his quadriceps with knee flexion and also by tapping the muscle. Patients may also exhibit muscle mounding or bunching up of the muscle and muscle spasms or contractions that can last up to a minute. Such symptoms typically occur when the muscle experiences a sudden impact, such as bumping into an object. Some patients with rippling muscle disease may also have muscle hypertrophy. Other symptoms include fatigue, muscle cramps, and stiffness. Symptoms are worsened by exercise and with exposure to cold. This video demonstrates percussion-induced muscle rippling and mounding in a patient with autoimmune rippling muscle disease. This video demonstrates a bodybuilder with rippling muscle disease and diffuse muscle hypertrophy. This figure demonstrates quadriceps muscle hypertrophy in a patient with RMD. Etiology: RMD can be inherited or acquired. Inherited cases result from mutations in the Cav3 gene or the Caveolin gene, which encodes for the muscle protein Caveolin 3. Inheritance is usually autosomal dominant. However, autosomal recessive cases can occur, and these cases may be more severe. Sporadic mutations are also seen. Caveolin 3 is important in regulating sodium channels within the muscle. It may also help to regulate calcium channels in the muscle and thus control muscle contraction and relaxation. In addition to causing RMD, mutations in the Cav3 gene may also cause the following: autosomal dominant limb girdle muscular dystrophy, also known as LGMD1C, Cav3 related distal myopathy, hypertrophic cardiomyopathy, isolated hypercikemia. Diseases secondary to mutations in the Cav3 gene are collectively referred to as the Caveolinopathies. Acquired cases of acquired RMD due to autoimmune etiology have been reported. These are associated with the Caveoli-associated protein 4 or Cavin4 IgG antibody in the majority of cases. Such cases may be associated with an underlying thymoma and may also have myasthenia gravis. Investigation: CPK levels may be elevated. EMG: needle EMG has been reported to show electrical silence in some cases. In other patients, motor unit potential discharges were noted in association with the rippling, and other cases showed bursts of short duration, low amplitude spikes. Muscle biopsy shows diffuse loss of sarcolemmal Caveolin 3 in the inherited form, while in the autoimmune form there is a mosaic pattern of Caveolin 3 loss. Genetic testing is performed in cases of suspected inherited RMD. Cavin4 antibody test should be ordered in cases of suspected autoimmune RMD. Treatment: autoimmune RMD has been reported to respond well to immunosuppressive treatment. Patients have been reported to respond to steroids, IVIG, plasma exchange, and azathioprine. Cases associated with a thymoma should undergo thymectomy. There is no curative treatment for inherited cases. Medications that can be used for muscle pain, spasm, and cramps include dantrolene, benzodiazepines, and calcium channel antagonists.